Hello, my dear students. So, we'll be talking about a very important topic and a very confusing topic in exam, that is stroke, in which we'll be seeing stroke, in which we'll be seeing cerebral artery occlusion alone. So, in stroke, when it comes to exam MCQ purposes, when they would present you with certain symptoms, you should be able to know which artery is occluded. So that's how probably you would be thrown a question with. So first you need to know the cerebral artery, because that is the most commonly asked in examinations. So I'd start with this. The cerebral artery is either anterior or mid or posterior, ACA, MCA and PCA. If you see this picture, this yellow distribution, the small yellow distribution, this is ACA, anterior cerebral arteries distribution, and the back side is of course posterior. So when you see the ACA almost cover the frontal lobe, the frontal and certain parts of the parietal lobe, and the PCA would cover certain part of the parietal, certain part of the temporal, and then occipital area. But most of the areas are supplied by MCA, the mid cerebral artery, the middle cerebral artery. So when it comes to your examination, the middle cerebral artery plays a major role. So first you need to build a concept in knowing how the patients would present. So this middle cerebral artery could present any of the presentations of either the anterior circulation areas being affected, either the frontal or the temporal or the parietal. The frontal, temporal, parietal, any of them could be affected. So the MCA, you need to keep in mind that would have vast number of presentations, whereas the PCA, in the posterior communicating artery area, the PCA area, there is something very important, that is the visual field. So here is where the visual field is located. So the visual field is affected in the PCA. So visual field is spared in the ACA. So here there is no visual area, so visual field is spared in ACA. So number one, you need to know whenever the anterior communicating artery is involved, visual field is not affected. That is a very important point that you need to know. So we would see certain points to differentiate between them. To start with, I put a word there. The difference between the ACA versus MCA. ACA involves lower limb. MCA involves upper limb, mostly. So patient would present with the facial features, and then the hemiparesis and the sensory loss. But in ACA, those will be for the lower limb. In MCA, those will be for the upper limb. So that's the first difference that I would like you to know. So in ACA, in lower limb, patient is going to present with hemiparesis plus sensory loss. Similarly, in upper limb, in MCA, again hemiparesis plus sensory loss. But these are in contralateral side. So the first difference in your MCQ is ACA means it's lower limb, MCA means it's upper limb. That's the first clue that you are going to differentiate between them. Now, provided that you have been confused regarding the limbs, what if they give both the limbs? Then you would look for another clue in MCA. Since MCA also covers the visual area somewhere here, so MCA would present with contralateral homonymous hemianopia, a visual field defect. In them, the patient would be able to visualize like this, a D-shaped area in both the sides. There is contralateral homonymous hemianopia, which means this other part of the vision is the half side of the vision is not seen. Okay, so that would differentiate ACA versus MCA. Now, so the differences I would like to put: ACA means lower limb, MCA means upper limb. ACA means it does not involve visual field, but MCA would involve visual field. So contralateral homonymous hemianopia, CCHH, is the major point that you need to know. Now, the same contralateral homonymous hemianopia can occur again in PCA, because in posterior circulation artery area the visual field defect is there. Now, how would you differentiate between the MCA versus PCA? In PCA, along with this contralateral homonymous hemianopia, the patient is also going to have something that is ipsilateral cranial nerve 3 palsy, which means look at the eyes of the patient. The side of the homonymous hemianopia patient is going to have, and look at the side of the cranial nerve 3 palsy, which means you are going to look at the eyes of the patient. So in cranial nerve 3 palsy, there is going to be down and out eye. So imagine this is normal eye, this is down and out eye. So down plus out eye. That's a very important point that you must remember in MCQ. So again, I'd like to repeat. I'd make it simple again. ACA versus MCA versus PCA. So in ACA, the vision is not affected. Only in MCA and PCA they are affected. In PCA, cranial nerve 3 is affected. The side in which it is affected is going to be the side of the lesion, so it's ipsilateral. If the right side is having down and out eye, it's going to be the right sided lesion, cerebral lesion in the posterior circulation area. In MCA, there is going to be hemiparesis and contralateral hemiparesis plus sensory loss. Hemiparesis plus sensory loss, which is the same in ACA, but ACA involves lower limb, MCA involves upper limb. So these differences would help you to differentiate. And in MCA, there is going to be MCA and PCA, in both of them there is going to be homonymous hemianopia. So when you see this picture in your image, in your MCQ question, and they ask which of the following cranial cerebral artery is most likely occluded, first thing you have to know, it's not a ACA, it's not anterior cerebral artery. So this presentation could be either MCA or it could be PCA. So next, what you're going to do, look at the gaze of the patient. So if the patient is having cranial nerve 3 palsy, the ipsilateral cranial nerve 3 palsy, which is the down and out eye, you have to brand it as posterior circulation artery stroke. But that is not given if the patient is look for the hemiparesis and sensory loss, because that's not going to happen in PCA stroke. So if they are talking about the hemiparesis and sensory loss, it's going to be the MCA stroke. So this differentiations should help you a lot in your examination. I hope this video helps. Thank you.